Hello, I am Raquel Simó. I'm a pediatrician gastroenterologist at Peset Hospital in Valencia, and I am here to talk to you about granulocytoapheresis, scenarios of use, and its safety profile. Okay, you know that ulcerative colitis is an inflammatory bowel disease, where there is inflammatory cell infiltration in the intestine. These inflammatory cells are above all activated leukocytes that move from peripheral blood to the intestine, to the colon, infiltrate the intestinal mucosa, attaching first to the adhesion molecules expressed in the endothelial cells. Primarily, granulocytes make up the highest percentage of these inflammatory cells and are a large source of pre-inflammatory cytokines, which are going to trigger this large inflammatory cascade. Peripheral blood monocytes and intestinal macrophage will also produce a large amount of inflammatory mediators, such as proteases or free radicals, which will be involved in cell damage as well. Okay, so this is the mechanism mainly involved in intestinal inflammation and which granulocytoapheresis is based on. It is a procedure that will allow us to cleanse the blood of different inflammatory substances, especially these cell populations that I mentioned before, these active leukocytes, as well as it allows us to modify the mediators involved in this inflammatory process. It consists of just the recirculation of the patient's blood by a circuit, as my colleagues mentioned before, passing through a column of different materials that selectively absorb all these cells. Two peripheral lines need to be inserted, if possible, in the patient, with the need to insert a central line being very uncommon, although in some cases we will have to resort to it. There are several systems on the market, but we only have one system on the Spanish market, where the columns are made of cellulose and selectively capture certain cells, mainly granulocytes, monocytes, and lymphocytes. It is a relatively simple system that works via a given flow in a peripheral vein, a system with a column filled with cellulose beads where these inflammatory cells remain absorbed, and then once filtered, the blood returns to the patient afterwards. Not only does it act on inflammatory cells in peripheral blood, but it also leads to an immunomodulation effect, and is possibly the basis for why granulocytoapheresis may make sense at the acute moment, as well as why it has its long-term effect. It has the capacity to increase the level of soluble tumor necrosis factor, alpha receptor, that possibly act by neutralizing this cytokine function. Moreover, leukocytes produce less inflammatory cytokines once they have passed through this system. A decrease in the expression of certain molecules in leukocytes, such as L-selectin and the specific receptor, and an increase in MAC1 integrity is also achieved, which means there is less leukocyte extravasation at the intestinal mucosa. There is also a decrease in intestinal interferon gamma, low concentrations of certain interleukins, which leads to less inflammation as well. Furthermore, the number of peripheral blood B cells, CD4 and CD25, and regulatory T lymphocytes increase, which will suppress intestinal inflammation via pathways involving interleukin-10 and transforming growth factor beta. So this is the system. All these effects are involved via passing through this column filled of cellulose beads system. Everything I told you before is achieved. It is true that we achieve a bigger immunomodulatory effect, the higher the number of sessions. The refractory cases will be the ones that need to specially consider this process. At least one weekly session is recommended for a minimum of 5 to 10 weeks, even though it is reported that an intensive regimen has become the most common regimen, the one we use most often. Initially 2 to 3 sessions a week for the first 2 to 3 weeks, and then 1 session a week, up to 10 sessions in approximately 8 weeks. There is a more intensive regimen, which consists of 5 consecutive sessions in 5 days. It's less used, but also has publications. Pediatric granulocytoapheresis is used in several therapeutic scenarios. and has frequently been used in corticosteroid-dependent, corticosteroid-refractory situations and in situations of immunomodulatory and biologic treatment failure. Granulocytoapheresis with adder-column is a procedure that we need to consider as interesting. It is a non-pharmacological and effective procedure in the setting of pediatric inflammatory bowel disease. This study now provides evidence that immunomodulation occurs post-granulocytoapheresis with leukocyte function changes. Not only does it clean leukocytes in peripheral blood, but also causes real changes to their functions. Furthermore, it increases the regulatory activity of the T and B cells that I mentioned before. It causes neutrophil apoptosis and a reduction in inflammatory cytokines. Furthermore, the patients that do respond to this type of treatment can achieve a favorable long-term clinical progression, thus avoiding those pharmacological treatments that we try so hard to avoid at the pediatric age. Other scenarios of use that we can focus on in the future, although some are already a reality now, I can think of several, and among them I would like to specially focus on the combination therapy with biologics, not only when they fail, but also in situations where immunosuppression of the patient does not suit us, or which involves an added risk for the toxicity they carry. When we want to prevent recurrence, for example, or surgery for a patient in whom we progressively see that his fecal calprotectin has a tendency to increase. Also in retreatment of patients with repeated cycles of apheresis as rescue therapy, combined either with 5-ASA or with corticosteroids. In those patients with inflammatory bowel disease and who have extraintestinal manifestations, granulocytoapheresis is known to also be used in diseases other than inflammatory bowel disease. And we can take advantage of this in patients that perhaps have psoriasiform lesions or any other manifestations outside the intestinal tract, the digestive system. And finally, I would like to consider the patients with inflammatory bowel disease and COVID-19 infection. Doing a little research, given the information we are receiving lately regarding the current pandemic. This is a recently published study including a pediatric study, which includes 24 patients of pediatric age between 11 and 19 years old, some of whom surpassed the pediatric age, and received 5-ASA as the first-line therapy. 17 patients relapsed or did not respond and were therefore rescued with granulocytoapheresis. 2 sessions were given the first week and then weekly until 11 sessions were completed. The patients that achieved a decrease, that is, who succeeded in decreasing the clinical activity index, continued with granulocytoapheresis, whilst those that did not respond received a dose of corticosteroids, between 0.5 and 1 milligram per kilo per day, or prednisolone, along with additional sessions of granulocytoapheresis, similar to those who did not respond. Of them all, 7 patients achieved remission with to 5-ASA. 5 patients did not respond to the first 5 sessions of granulocytoapheresis and received corticosteroids and granulocytoapheresis. And 12 patients did respond to the first 5 sessions of granulocytoapheresis and continued with additional sessions. They concluded that, in patients with active ulcerative colitis resistant to first-line therapy, granulocytoapheresis led to clinical remission and mucosal healing, whilst those that did not respond to monotherapy with granulocytoapheresis, the addition of low-dose corticosteroids improved the efficacy and enabled the gradual treatment withdrawal. Regarding the combined therapy with biologics, there have been multiple cases published in our country. The first case was reported in 2006, a patient with chronic Crohn's disease who had a loss of response to infliximab. He underwent maintenance therapy sessions every 8 weeks, alternating with biologic infusions. Subsequently, a second case was reported of a patient with ileocolonic Crohn's disease with a loss of response to infliximab as well, who underwent monthly sessions of granulocytoapheresis as maintenance therapy, achieving remission. Subsequently, 10 patients with active severe moderate ulcerative colitis were reported, who started adalimumab along with an intensive apheresis regimen, 2 sessions a week during induction, and subsequently maintenance therapy with adalimumab in monotherapy. They achieved clinical remission in 36% of the patients after 10 weeks, and in 33% of the patients at week 52. Regarding the combined therapy with biologics, this is a multicentric, retrospective study that was carried out in 11 units of inflammatory bowel disease, which included 47 patients with ulcerative colitis, and also concluded that the combination of granulocytoapheresis and biologic therapy is a safe and effective treatment after the loss of response to biologic, with a significant decrease in the clinical activity of the disease and inflammation biomarkers in a population with limited therapeutic alternatives, such as the pediatric age. In situations of retreatment, we need to keep in mind that there is a possibility of retreating patients with repeated cycles of apheresis, as shown in a Swedish cohort study publication, which included 40 patients with inflammatory bowel disease resistant to conventional treatment, who were treated with granulocytoapheresis and achieved both clinical and endoscopic remission. Of these, 26 had recurrence during follow-up and were retreated with continuous cycles of cytopheresis, achieving remission in essentially all of the patients. Some were retreated up to 5 times. Regarding granulocytoapheresis, after the first-line therapy failed, we have the ADAPT study, which Dr. Donat mentioned before. I am not going to go back over it, but I am going to simply highlight that apheresis treatment is considered an effective treatment in pediatric patients with moderate ulcerative colitis, and we should not forget that it is a therapeutic option for pediatric patients in whom the first-line therapy failed, without having to use more aggressive treatments. Concerning recurrence prevention, considering that mucosal healing constitutes a key goal in the treatment of our patients, associated with reducing the risk of recurrence and the need for surgical treatment. Apart from the effects of apheresis on the elements of the immune system, studies on colonic mucosal changes have been of great interest. Apheresis can constitute an alternative for IBD patients at high risk of recurrence, primarily in those that have fecal calprotectin upward trend. Concerning inflammatory bowel disease in pediatric patients and COVID-19 co-infection, although several treatment regimens have been proposed for inflammatory bowel disease and COVID-19 patients in acute or severe situations, we see that therapeutic options are limited. There are appearing publications mainly on adult cases and much more restricted at the pediatric age. One publication caught my attention that was fairly recent in 2022, even though it is an adult case. The patient had active ulcerative colitis in remission through the removal of activated myeloid cells without the use of an immunosuppressive therapy, just with apheresis. He was a 25-year-old patient with active, severe, moderate, and severe COVID-19 infection. It is the first report on a case of induction of remission of ulcerative colitis with apheresis of granulocytes and monocytes treatment in active colitis associated with COVID. The summary, after our chat on the possible scenarios of use of pediatric granulocytoapheresis would be the usual treatments for granulocytoapheresis or the usual use of pediatric granulocytoapheresis would be shown in the top section. And then in the bottom section, the slightly more uncommon treatments would be mentioned. Lastly, concerning the procedure safety itself, we know that the pediatric age, per se, is a group of patients with specific characteristics, requiring safe treatments and without any adverse events, especially associated with the patient's growth. We evaluate apheresis as a safe therapeutic option for this group of patients, particularly in limiting those treatments with the highest toxicity, mainly corticosteroids. The observed adverse events are generally mild, such as pain at the injection site, headache, flushed skin, fatigue, chills, nausea, vomiting, but none of these are seen as leading to treatment withdrawal. Special precaution needs to be taken in situations where concomitant infections are present or suspected, in situations of heparin, hypersensitivity, patients with a low erythrocyte count, situations of severe dehydration, situations of blood hypercoagulability, or situations in which none of these parameters are normalized. Also in situations of fever, with temperatures over 38 degrees. We should also be cautious in situations or in patients that are subjected to drug treatments, such as angiotensin-converting enzyme inhibitors. In these patients, we should be very thorough in the follow-up and monitoring of blood pressure and heart rate, in patients with severe cardiovascular disease, and in patients with liver and kidney failure. What limitations might we encounter? Fundamentally, at the pediatric age, the biggest limitation is venous access, although it is not a major limitation. It is generally, or probably is, the only limitation that we have, particularly in those patients that are overweight, obese, or patients with severe vascular fragility. And lastly, the patient must be hemodynamically monitored throughout treatment, obtain peripheral access whenever possible, have a baseline analysis including coagulation parameters, as well as after the third apheresis session and at the end of the induction cycle, and assess the efficacy of pediatric granulocytoapheresis after steroid withdrawal, and systematically record all clinical information. This is the end of my talk. Thank you very much for listening.